answer yes or no, and also to the extent of this examination. And but it's not so really easy, and so I wanted to show you a case report just to discuss perhaps with you. And this is a 28-year-old triathlete who came to our outpatient clinic for a pre-participation screening before Ironman challenge in Germany, and he was had a pretty good health and no really illnesses before and no drugs, and I think this is a realistic training history, about 15 to 20 hours just 3 months before the competition. And if you look at the examinations we had, the resting ECG was totally normal, and also the clinical chemistry showed no abnormal values. And then regarding the exercise testing, at a, for him, pretty low capacity of 225 watts, there was a sudden increase in heart rate up to 240, and with another form of the QRS complexes, and it has an inferior axis and LBBB form, and so it was a ventricular tachycardia out of the right ventricular outflow tract. So this persisted for about 1 minute. The patient was conscious. We asked him what's going on. He said, "Hey, everything's fine. I don't have any angina, any pain, no tachycardia." And then we put him down from the cycle, and he was a little bit surprised. And this was after laying him down, and there was a spontaneous conversion into a sinus rhythm. And then we fixed the Davy patches because we might defibrillate him. And before the insertion of an IV, there was a spontaneous conversion. And so this case, this was highly suspicious for a catecholamine-sensitive right ventricular outflow tract tachycardia, and so we performed some additional examinations also with the Holter ECG, which was pretty normal, a cardiac MRI to rule out arrhythmogenic right ventricular dysplasia and a myocarditis, and we also did an electrophysiologic study, and there we found an SVT origin in the right ventricular outflow tract. Also regarding the molecular genetic examination, we found a mutation of the ryanodine receptor. So you see, this is a lot of diagnostic just after this exercise testing, and the consequence was that he got a therapy in accordance to the guidelines with a beta blocker, and he was disqualified from any competitive sports. So is this so unusual, or is it a usual case? And perhaps we can discuss afterwards. So we know about the benefits of exercise and the hazards. So regular, moderate, intense exercise can decrease the all-cause mortality, not only cardiovascular disease, but also cancer and pulmonary disease. And there's a close association between here coronary artery events and the level of physical fitness. So what are the underlying mechanisms? First of all, it's a modification of the classical risk factors like blood glucose, blood lipids, and also the blood pressure, but also an improvement of both endothelial dysfunction and the autonomic balance. But also the platelet aggregation is diminished within regular, moderate, intense exercise. So the other side of this medal is the known association between vigorous exercise and an increased risk of some cardiac events. And there seems to be a U or J shape, I think. David will also show us this hormesis regarding exercise. And there you see it's an angel and a devil on the shoulders. And we try to keep the angel more prone than the devil. So we have to weighten this risk-benefit ratio, and important factors are the individual's age, and the presence of any underlying disease and the actual fitness level. So, with regard to the health screening program, there are several criteria which were set in from the World Health Organization in 1968. And there are 4 criteria. The first one is that the investigated condition should be an important health problem. I don't know whether this is, but perhaps we will get an answer. And then there should be a test or examination for this investigated condition and a treatment. Because if there isn't a treatment, then you don't need to test for this condition. And also this condition should be detectable at an early stage, so that you can prevent the ongoing of this condition. And this is very important that the costs of the finding of a case should be economically balanced in relation to the medical expenditure. So this is also one point which might be a little bit different in the pre-participation screening, because they are especially younger athletes and there you gain more years of life than an older one suffering a myocardial infarction. So I don't know whether we can answer this question at the end. So, is sudden cardiac death in marathon runners, is it an important health problem? If you look at this slide, and these are the latest data from 2011 from the National Vital Statistics Report, then you have to say no. Because the mortality rate compared to other really serious events like myocardial infarction or alcohol or prostate cancer, and also to smoking, is so low. It's only 1 compared to 200. So we have to say it's no important health problem. However, for the individual suffering a sudden cardiac death during sports, it is an important health problem. So if you remind the criteria from the World Health Organization, we can stop our talk here, because the first criteria isn't met, so we can stop. But because we want to go on and going to discuss all the other criteria, I will show you some other slides. And the second question is whether there is an effect testing or also a treatment. And you all know the data from the Venetia region published by Corrado. And there you see the sudden cardiac death rate before the introduction of pre-participation, which decreases significantly over the period of about 30 years. And therefore, in the last years, the risk of sudden cardiac death in the screened population athletes, they were even lower than in the unscreened non-athletes. And so you see that it's effective. But you have to know that the causes here, they are a little bit different from the other ones, because there was a pretty high proportion of athletes with arrhythmogenic right ventricular dysplasia within this age group, and this can be in parts detected by ECG and the other screening methods. So this is a very recent paper, and here are the current recommendations regarding the evaluation of middle-aged and senior individuals. This is the typical marathon runners. When you remember it, it's about the age of 42 to 45 in mean age. And this is the consensus statement, and I will focus on this consensus statement now. And the aim of this consensus statement was to establish a practical method, and this is very important, because if you don't have a practical method, then no one will use it, and so the paper isn't it worth to be published. But I think this is a very practical method described within this paper, and so I will present it to you. And another intention is to encourage individuals to participate in regular physical exercise. And this is also very important, because we don't want to make someone frightened of exercise because of the potential risk, which is pretty low, of sudden cardiac death.